Welcome everyone. My name is Kristen Wayner and I am with Sachs Healthcare Communications, the provider of this educational activity. Thank you for joining us for the first of a three-part series of webinars that focuses on the risks and management of catheter-associated thrombosis. The title of today's webinar is New Concepts in Peripherally Inserted Central Catheter Insertions, Understanding Catheter Vessel Ratio and its Impact on Venous Stasis and Individualizing PICC Selection for Positive Patient Outcomes. Speaking on these two related topics are Dr. Thomas Nifong and Ms. Cheryl Kelly. Dr. Nifong joined Metamark Genetics with extensive experience in molecular pathology, clinical laboratory medicine, and laboratory validation and management. Prior to Metamark, Dr. Nifong was Associate Professor of Clinical Pathology at the Penn State Hershey Medical Center, where he served as Medical Director of the Molecular Diagnostics Laboratory, Medical Director of the Hematology and Thrombosis Laboratory, and Staff Physician in Clinical Pathology and Apheresis. He provided direct patient care through blood exchange therapies and through laboratory testing and interpretation. Dr. Nifong's research experience includes mathematical modeling of blood flow-related systems and profiling the thrombotic complications of artificial organs. Dr. Nifong has lectured both nationally and internationally on the topic of catheter-related thrombosis. Cheryl Kelly is a Senior Vascular Access Clinical Specialist with Teleflex, Inc. Since joining Teleflex in 2007, Ms. Kelly has been instrumental in raising awareness in the vascular access community around the risks and complications of catheter-associated thrombosis. Prior to joining Teleflex, Ms. Kelly was a vascular access specialist for West Virginia University Hospital in Morgantown. She wrote many policies and procedures related to vascular access management, which served as a good foundation when she created and implemented the hospital's PICC team. Ms. Kelly is active in the Association of Vascular Access and has served on multiple committees and most recently was the chair of the 2010 annual meeting of AVA. Our learning objectives for this webinar are to, first, define catheter vessel ratio and the methods for determining it. Second, to describe how catheter size can negatively affect blood flow dynamics in peripheral vessels that may lead to enhanced risk of thrombosis. And lastly, to outline 3 proactive, evidence-based risk reduction strategies to drive patient safety and improve clinical outcomes during the use of a peripherally inserted central catheter. At the end of this webinar, you can obtain 1 contact hour by going to www.saxtesting.com/BH and completing the post-test and evaluation form. Upon successful submission, you will be able to print out your certificate of completion. The provider, Sachs Communications, is approved by the California Board of Registered Nursing, provider number 14477. No off-label use of products will be discussed. Disclosure, Dr. Nifong is a paid consultant for Teleflex. There will be a Q&A session at the end of this webinar. Please type and submit your question from the questions section of the control panel to the right side of your screen. And now, please join me in welcoming Dr. Nifong and Mrs. Kelly as they present new concepts in peripherally inserted central catheter insertions.
Thank you very much for that introduction, and welcome everybody. I guess it's a good day on a webinar since people are at different time zones. As a little bit of background, prior to the widespread implementation of central venous catheters, upper extremity thrombosis really wasn't much of a problem. But now, regardless of the insertion site, whether it's centrally inserted or peripherally inserted, it's really quite a prevalent problem. Focusing on PICC-associated upper extremity thrombosis, if you scan across the literature, there's really a very wide distribution of the occurrence rates. And what I'm showing on this table here are some of the commonly cited publications, and I've organized them in a way to help make sense of the widespread numbers, which range from less than 2% to about 40% on the ones I listed here, but actually some are even higher than that. If you look at the first 6 publications that I show here, what they have in common is these are all looking at the symptomatic rate of thrombosis. And with symptomatic thrombosis, it's anywhere from around 2% to close to 8%. The next citation here by Gonçalves is looking at an asymptomatic risk of upper extremity thrombosis. But when you look at how the study was performed, they actually only visualized the most centrally located veins, so from the axillary and above. And they show an asymptomatic rate of 7%. But when you look at the last 2 papers here by Abdullah and Allen, they looked at asymptomatic rates, but they performed venograms and analyzed the entire upper extremity. And this is where they found very high rates, close to 40% in the Abdullah study. So this is clearly a common problem that we have to deal with. Now, by way of comparison, let's look at the other common complication of centrally placed catheters, and that's bloodstream infections. Now, the CDC data that was presented back in 2002 showed an average rate of 5.3 infections per 1,000 catheter days. If we consider a catheter duration of 7 days, this equates to a rate of about 3 to 4%. Now, this is clearly a serious complication, and there was a real call to action based on this that over the past several years has helped to reduce that rate. Now, the other question then is, upper extremity thrombosis really clinically important? And up until the mid-1990s, it was really ignored altogether. In 1994, Montreal had a publication in Thrombosis and Hemostasis where they looked at 86 patients with PICC or subclavian-related DVTs, and they found that the complication rate was 15.3% when they did VQ scans in these patients. A similar study was performed by Prandini in 1997, and in that case, they found 36% with confirmed pulmonary embolism and 15% with post-thrombotic sequelae. Now, in both of these studies, the investigators, in the patients that did have pulmonary embolism, they visualized the lower extremities as well to confirm that this wasn't just a coincidental finding. Now, granted, these weren't lethal events, but I would argue that we really don't want to have a pulmonary embolism at all. Now, a more recent study by Lobo published in 2009, now this study involved 777 patients with PICC lines, and 38 of the patients were shown to have a venous thromboembolism. And so there was symptomatic PE found in 1% of the total patients, though. So this, was not just an incidental finding. It was truly a symptomatic complication. And the final study I show here by Ong really wasn't looking at the immediate complications of pulmonary embolism, but rather they followed 76 patients with PICC-related DVT over the course of a year, and what they looked at was the post-thrombotic sequela. 25% of these patients had mild pain, 2% moderate pain, and 15% had upper extremity edema. So there's certainly plenty of literature to suggest that this is not only a common complication, but also is clinically relevant. Now let's take a look just for a moment at the physiology behind this. Now, hemostasis is actually a physiologic process by which bleeding is halted. And in order to accomplish this, it really requires a delicate balancing act. So there's a coagulation system which is designed to generate thrombin. And then it's opposed by an anticoagulant system, which is designed to inhibit thrombin. And the balance between the two of these, when there's an injury, should shift briefly toward coagulation and allow a blood clot to form. And then the fibrinolytic system also kicks in order to control the extent of that blood clot that forms. Now, however, we're all aware that there are factors that can come into play that can upset this balance. And these factors were originally described in the 1800s. Rudolf Virchow is usually cited as sort of the first thinker in this area, although he never really put this triad together. But the factors that contribute to tipping this balance are stasis, or alterations in blood flow, vascular or endothelial injury, and underlying hypercoagulability. And so when this delicate balance is upset, then that can switch it from what is a normal physiologic process into a pathologic process, such as in this example here, which is a brachiocephalic thrombus that formed, and this is almost completely occluding this vessel. Now, when we look at catheters, the catheters certainly contribute to upsetting this balance through stasis and vascular injury, but they also introduce a thrombogenic surface, and certainly this is another factor that was not even considered back in the 1800s. Now, I talk a fair bit on this topic, and as I look at the risk factors for catheter-related thrombosis, I like to break them down into a couple of different categories. The first being sort of an anatomical consideration related to the insertion site. And as I mentioned at the beginning, thrombosis is a complication regardless of where the site is. But there are some dependencies upon where the catheters are inserted. It has been shown in studies that the highest risk occurs in femoral veins. And when you're considering hemodialysis, there's clear evidence to show that the internal jugular vein carries the lowest risk. There's some data to suggest that the internal jugular is preferable for tunneled catheters as well, or that, for tunneled catheters as well. There are a couple of very well done studies that show that the subclavian does in fact carry a low risk for the ICU setting. There are some strong opinions in this area of whether the IJ or the subclavian are preferred in the ICU setting, but nevertheless, with proper care, they can both be safely placed. When we look at the PICC lines, the complication rate from thrombosis is similar to that of a subclavian when we consider just the deep or the central venous thromboembolism. But when we look at the total peripheral veins in the upper extremity, it's actually a considerably higher rate. As I mentioned before, asymptomatic rates up around 40%. So the next considerations are really related to what we do to the patient when we insert these catheters and leave them in. And so I break this down into the endothelial damage and the venous stasis. Now, from an endothelial damage standpoint, we really cause damage at two different sites. First, when we're inserting the catheter itself, we're creating endothelial damage. And then second, the tip itself creates damage. Now, at the insertion site itself, a common complication is just traumatic phlebitis. And certainly the nurses in the audience see this as a very common complication. underlying the phlebitis most often is just a sterile vessel wall inflammation, but a certain subset of those are actually superficial vein thrombosis, and this can actually lead to further complications where it becomes a true thrombotic complication. Now, here's a study that was performed by Agnes and published in 2006, where they evaluated the baseline characteristics of 444 patients with a total of 500 catheter insertions, and they tried to discern which of these baseline characteristics were predictive of thrombotic complications. And they found two factors that were statistically significant. The first was patients where more than one insertion attempt was required. And in that case, the odds ratio was 5.5. And the second was in patients that had a previous catheter inserted. And in that case, the odds ratio was 3.8. In both of these cases, one could argue that these factors are related to some element of endothelial damage. Now, as I mentioned, then the other region where we create damage is at the tip location, and this is a fairly non-controversial topic at this point. There are a number of studies that support the importance of the tip location. Now, this is a study, though, that was published by Luciani in 2001, and they looked at 145 patients, all with the same type of cancer with implantable CVCs. And they initially confirmed the tip location with chest x-ray, and then they followed the patients monthly with Doppler ultrasound. Now, in this study, they broke down the tip location to 5 different segments. And see if I can get my mouse to come on here. And so segment 1 here, it really represents the optimal placement of the catheter, and this would be in the atrial caval junction. And then segment 2 moving a little further away, 3 and 4, etc. And so really the optimal placement is going to be down here in 1, and perhaps 2 being an adequate location. And when they then looked at the complication rate of thrombosis, depending on the segments, they found when it was appropriately placed, the rates were between 5% and 8%, but when it was pulled back so it was in the further up in the superior vena cava or above, it actually was anywhere from 30 to 70% risk of thrombosis. And this has been confirmed in a number of other studies. I won't go through all of these here, but one interesting study out of this group is shown here by Tessalere et al. And published in 2004. And they looked at 243 patients with implantable ports, and specifically looking at symptomatic DVT. They found that it was 2.7 times higher in the superior vena cava as compared to when it was actually placed in the right atrium. So as I mentioned, relatively non-controversial, though, that this should be as close to the atrial caval junction as possible. Now, the next factor that can influence the risk of thrombosis then is the alteration in blood flow, the venous stasis. Now, we'll take a look again at the pathogenesis of catheter-related DVT. And what I want to show here is just that it's really multifactorial. It's not just one of these that causes thrombosis, but we really have at the insertion itself, we caused on endothelial trauma. We then have, depending on the tip location, some degree of ongoing endothelial trauma. We then have patients, some of which are more susceptible to others with an underlying hypercoagulability. And we know that many of our patients that require central catheters have risk factors such as malignancy. And then, as we leave the catheter in, we have some element of ongoing stasis that occurs or flow alterations. And it's the combination of these that lead to catheter-related thrombosis. So ideally, what we would like to do is prevent this from occurring. And when we look at the insertion trauma and tip location, we actually have a pretty good tool at our disposal in order to accomplish this. And these are the imaging technologies. So certainly with the use of ultrasound-guided insertions, we can limit the number of attempts that are required and therefore reduce endothelial trauma. And we can also use imaging either in real time or post-placement in order to confirm that the tip is appropriately located. So we do have tools at our disposal. The other possible way to help prevent this is looking at the underlying hypercoagulability. Unfortunately, though, right now we really don't have a good mechanism in order to select out patients for prophylactic anticoagulation in an effective manner. There are a number of studies that have been presented, some showing a benefit, some not showing a benefit, but this is a publication by Carrier from 2007 in the Journal of Thrombosis and Hemostasis, where they performed a meta-analysis, looked at the compilation of the available studies, and what they show when you look at the summation here is a relative risk that is just slightly on the favorable side, but it spans 1 and really was not considered to be significant. And so based on that, the chest physicians publication in the 8th edition recommended to not use prophylactic doses of either low molecular weight heparin or the mini-dose warfarin to try to prevent this complication. So there may be something in the future that is effective for this, but right now we really don't have a great tool in order to prevent that. So unfortunately, that leaves us with having to treat this relatively common complication. And the treatment itself does depend on the location of the thrombosis itself. So the current recommendations are really if it's in one of the smaller vessels, such as the basilic, the brachial, or the cephalic, that the patient has conservative management along with catheter removal. And of note, in some of these patients it will recur or extend even though the catheter is removed, and that would in fact warrant anticoagulation. In other cases, it's just to keep in mind, when you remove the catheter itself, this will likely lead to a relatively small pulmonary embolism. There is a clot formed around that catheter, but when it's a more centrally located thrombus that forms, then this is really a DVT and has to be treated as such. So it's recommended in that case that since the patients should be placed on full anticoagulation with either unfractionated or low molecular weight heparin or fondaparinux, and then maintained on warfarin or low molecular weight heparin, that in fact the catheter does not have to be removed as long as it's still functional and needed. Now, the other area where we can potentially help to prevent thrombosis is looking at this issue of ongoing stasis. And from a clinical standpoint, there were a number of papers that have been published over the past decade and a half that show clearly that there's a relationship between the size of the catheter and the risk of thrombosis. Important one shown here, Grove and Pivac, published in 2000, showed a statistically significant difference between the event rate and the catheter size. And for example, with 4 French PICCs, the rate was 1%. With 5 French PICCs, 6.6%. And with 6 French PICCs, it was almost 10%. Another study published by Allen in 2000 was not looking actually at the size of the catheter. These were essentially all 5 French PICCs that were placed. But what they did note was there was a dependence on the vessel size, and the smallest, typically the smallest of those vessels, the cephalic, had a much higher rate of thrombosis. And then the study published by Evans in 2010 really backs up what was previously published by Grove and Pivac, showing this dramatically increasing rate of thrombosis depending on the catheter size. Now, given this literature that has been published, we look to see what, if there are any standards or guidelines to help us with to try to minimize this risk. And when you look at the INS standards, there's sort of a loosely worded guideline, and that is that the target vein must be able to accommodate the catheter. But what does that really mean? And so we put together this study really as laying some groundwork here. And we sought to estimate, both by doing mathematical modeling as well as an experimental model, to look at the specific impact of how catheters affect fluid flow rates. And like I said, to start to establish some groundwork anyway to put together guidelines for appropriate catheter and vein selection. Now, hopefully you haven't finished your lunch yet, and that you're a postprandial nadir here, because I'm going to spend a couple of minutes on some of the flow dynamics here. Now, most of you have probably seen this equation before, or at least familiar with Poiseuille's law. The bottom line of Poiseuille's law is that the flow in a tube depends on a 4th power relationship of the radius or the diameter of the tube. And so where this comes from, this is a fluid dynamics equation that was derived to describe the flow of a fluid in a cylinder. And so trying to get my find my mouse here. So what that means is that the flow is positively affected by the flow is positively affected by the diameter or radius of the cylinder. So the larger it is, the more flow that will go through it. And that makes sense. And also positively impacted by the pressure that is driving the flow of the fluid. But it's also negatively impacted by frictional forces. And those frictional forces depend on the length of the tube. So the longer it is, the more friction that will be present. But also then internally within the fluid itself. In a small cylinder, the fluid internal friction is exacerbated, and also the fluid friction is highly dependent upon the viscosity of the fluid itself. When we're talking about blood, that really means the cytocrit. So patients who are hemoconcentrated or have a very high leukocyte count will actually have more sluggish blood flow. Now, so in simple terms then, what this means is as the diameter of a tube, all other conditions remaining constant, increases, we have a 4th power increase in the flow rate. Now, when we place a catheter inside of a vein, though, this completely changes this flow dynamic. And instead of having flow in a cylinder, we have what's called annular flow. And the annular flow now has frictional forces not only at the surface of the vein and the internal fluid, but also along the surface of the catheter itself. And if truly centrally placed, that catheter will actually block what's otherwise the highest velocity portion of the flow. And this ends up turning into a much more complex mathematical model. The bottom line of this is that the flow of the fluid is highly dependent on the ratio between the catheter or the centrally placed object and the diameter of the vein or the cylinder. And what this animation shows is that that relationship actually changes in a dynamic way depending on where the catheter is actually placed within the cylinder. And the closeness of the lines in this animation reflect the degree of friction that is present. And when they're spread out, that shows high velocity. So when it's centrally placed, we actually have a very small portion of the catheter, which of the vein, which really has high flow. Now, we modeled the system in that manner, and then we also, in order to back that up, performed an experimental model as well. And so what we designed here is a system to maintain a constant pressure to allow a blood analyte, this was a glycerol solution with a viscosity similar to blood, to flow through the glass tubes here, and we were able to insert stainless steel rods of sizes that would approximate the flow of the size of PICC lines that would be placed. And so the results of this study are shown here. They're actually combined on this plot are both the mathematical and the experimental models. And so if you look at this lower curve here, this lower curve represents what we expect to happen based on the experimental model if the catheter is truly placed within the center of the vein or the cylinder. And so on the x-axis here, we show the ratio between the catheter and the cylinder. And on the y-axis here, this is the relative flow rate. So, for example, if we have a 0.3 or 1/3 ratio of the catheter to the cylinder, that will in fact decrease the flow rate to about 1/3 of the original flow. On the upper curve here, what we show is what the obstruction would be if the catheter was actually at the cylinder wall. So at the cylinder wall, we see that it has less of an impact on the flow. And the dots that are shown here are actually the experimentally measured values, which you can see fall somewhere in between the two extremes, probably a reflection partially of the imperfection of the experimental model itself, and the inability to truly control the central location of that stainless steel rod. Now, on the table here, what I've taken is actually the mathematical modeling and extrapolated from that sort of discrete points that represent what we would see with various vein sizes and various sized catheters that are centrally placed. And so, for example, the cephalic, which is has a diameter of approximately 4 millimeters, an unobstructed flow rate would be about 10 milliliters. And if we were to place a 4 French catheter in there, that would be we would end up with only a flow of 3 milliliters or 28% of the original flow. If we were to look at the basilic with an approximate size of 6 millimeters, and we place a 6 French, we would have a similar obstruction because that catheter to vein ratio is the same between those. Now, we don't really have a magic number in order to say this is the critical point at which we're going to perturb the blood flow and cause or precipitate a thrombosis. But we do know from some basic science research some of the things that happen during low flow conditions. So, for example, in this study here, in an in vivo rat model, where the blood flow was specifically decreased to prescribed shear rates, which is really a function of the flow. What they found was at these lower flow rates, the neutrophils interacted with and bound to the endothelium. They became activated, and then they in turn attracted platelets. So under low flow conditions, we actually end up with essentially a prothrombotic condition with platelets lining the endothelium. Another study here, going way back to 1968, shows that as the flow rate is decreased and along with that the shear rate goes down, the red blood cells normally repel each other with negatively charged proteins on their surfaces. But under these low flow conditions, they actually start to interact, and the viscosity of the blood goes up. So as we obstruct flow and we slow it down, the viscosity goes up, and that can further exacerbate the flow conditions. And then finally, something a little bit more clinically relevant here is a study looking at 94 stroke patients in 3 different studies where the DVT location was reported. They found that of those patients, 66 of them had a DVT that was in the paralyzed leg only. And so presumably this much higher rate in the paralyzed leg is a reflection of the altered blood flow within that leg. Now, we certainly have made some assumptions and have some limitations here in our study. Now, our models represent a simplification of the venous anatomy, and we're really looking to just highlight the effect of the mechanical obstruction on flow. So we're trying to isolate just one part of this very complex system. A true venous system has a more complex hemodynamics. There's a pulsatile blood flow that's really induced by the skeletal muscle contractions. There's a system of parallel branching veins, and there's also some curving and tapering that occurs. These veins have some adaptive ability to dilate as well. But nevertheless, we come back to what this means from a clinical standpoint, and to highlight again the study by Evans that was published in Chest in 2010. This shows that when we look at 4 French catheters, the rate was 0.6%, 5 French catheters, 2.9%, and 6 French catheters, the rate is at 8.8%. So there's clearly a role of flow alterations that's occurring in these with these larger catheters. And another study that was published in 2010 in the Journal of Thrombosis and Hemostasis is a meta-analysis where they compiled data from 12 different studies. This is not confined to PICC lines, but it's all types of CVCs, implantable as well as temporary catheters. But in this large study, there were 5,636 patients, and there were 425 catheter-related thrombotic events that were observed. So a very large study. And now the authors concluded a thrombotic risk associated with just 4 factors. It was higher with PICCs versus ports. It was higher with a subclavian venipuncture. It was higher in patients that had a previous history of DVT. And also, not surprisingly, it was higher with improper positioning of the catheter tip. I'm not sure why they didn't mention the following, but in the primary data that they also presented within this paper, they show the thrombosis status as it relates to catheter size. And in this line here, they have the smaller catheters, so these are 6.5 French and smaller. And again, these are all types of catheters that are placed. But the event rate is, there were 97 events out of almost 2,000 patients. And so this is a little bit less than 5%. But when you look at the larger catheters, so greater than or equal to 6.5 French, there were actually 246 events in a similar number of participants, and this works out to about 13%. So, you know, we really have, I believe, a call to action here to pay attention to how we're some of the preventable factors for thrombosis. And so I really appreciate that in the CHEST journal with a submission that they really require of the authors to put in a couple of comments on the bottom line. And the first is, how does this work advance the field? And, you know, as I hope I've demonstrated through this presentation, there's really clinical data out there that already shows that there's a risk of catheter-related thrombosis related to the size of the catheter. But it truly hasn't addressed how the increased catheter size may play a causal role. And so what we hope to do is that our modeling described both the factor of catheter size as well as vein size, and helps to quantify the impact of this relationship on fluid flow. And what we have done, and the data that we present, suggests that the flow rates are highly dependent upon this relationship. And from a clinical standpoint, really the clinicians are faced with balancing risks and benefits in everything that they do. And larger multi-lumen catheters can't be avoided. However, we feel that by further exploring this catheter-to-vein relationship in a clinical model, perhaps a threshold could be determined that shifts the risk-benefit ratio. And you know, in some cases where patients in fact need larger multi-lumen catheters and they don't have a favorable catheter-to-vein ratio if peripherally inserted, then you know, those patients perhaps would benefit from centrally placed catheters as well. Now, you know, so over the past 45 minutes, I really hope that I've, you know, helped to bring to your attention both some of the literature to back this up, as well as you know, show the data from our model, and you know, some of the novelty in this. But also the important thing is, and why we did this, is we want to impact behavior in the future. And there was a very nice editorial that was published in CHEST alongside our publication, and it it really has a call to action for clinicians. And over the next few minutes, Cheryl Kelly is going to address some of these more clinically oriented issues, and again, hopefully we can get a call to action on this. Cheryl?
Thank you, Dr. Nifong. I'm going to take just a few minutes to conclude our presentation today by talking about some issues that Dr. Goldhaber, in his editorial to the Chest Journal, some of the information that he submitted in his editorial, and issues where we really need to think about, as Dr. Nifong said, why we're using PICCs, and are PICCs the most appropriate line to use? Should we be looking at some of these issues before we make our decision of the line? The first thing I'd like to talk about is what happened, where did PICCs come from? Why are they so popular? As you know, PICCs came to the realm in the late 1990s, and with the incorporation of vascular access teams and PICC nurses, they certainly have taken off. When we look at PICCs in general, PICCs are safe. There are insertion teams that are very skilled at inserting these lines, and they are good lines to follow the patient home whenever he's discharged. So let's talk first of all about the device location. When you look at the safety of PICCs as compared to central venous catheters, the risks are actually lower than a central venous catheter when it comes to the insertion complications. Even though the insertion complications with CVCs are rare, they are quite serious, and most generally those are complications such as hemothorax, pneumothorax, or carotid or subclavian artery cannulation. Of course, the implementation of ultrasound has certainly helped us decrease some of these risks. When we look at the complications that are associated with the dwell of the devices, whether it's a CVC or PICC, those complications seem to be similar. And examples of those are things like thrombosis, occlusion of the catheter, or infection. When we look at the infection risk of PICCs, it is generally understood that the infection rate with the PICC is less than with the central venous catheter, and most certainly the early statistics that were gathered on PICC insertion supported this theory. However, in 2006, Dr. Mackey did a meta-analysis of infection rates related to various types of catheters. And in PICCs, he found that the PICC infection rate for an inpatient was 2.1 per 1,000 catheter days. And then he compared that to the data that he collected on non-medicated central venous catheters, and the rate was approximately 2.7 per 1,000 catheter days. And then the PICC rate of 2.1 was actually greater than the rate with medicated central venous catheters, which was 1.6 per 1,000 catheter days. So when we look at how are the rates comparable between PICCs and central venous catheters, as you know, it has to do with the sources of infection that are present with the patient and with the patient's line, intraluminal, extraluminal infections. When you look at the thrombotic risk associated with PICCs and central venous catheters, as Dr. Nifong mentioned, we need to look at symptomatic versus asymptomatic. And so the rates, basically, when you look at symptomatic or asymptomatic, are somewhat similar between the two devices. The significance of the thrombosis that the patient may or may not experience related to his PICC is more important when you look at patients that have a tendency to be hypercoagulable, and that generally would be the oncology patient. So whenever we look at the thrombotic risk associated with central venous catheters in the oncology population, one must certainly consider the relationship between thrombosis and infection in this population, and certainly do a risk-benefit analysis comparing the two. When we look at PICC insertion teams, the insertion process that these teams use, there's certainly a highly skilled group of clinicians that are inserting these devices. Generally, each hospital has some type of PICC insertion team or PICC program established in their facility. They may have specialized rooms to insert these lines. Then maybe they're placed at the bedsides. The equipment that is used for the insertion process has streamlined the process so that it is quick and it's accurate and it's precise. The incorporation of ultrasound, things like max barrier kits and tip verification systems have made this a process that is quite successful. The process certainly should include team members in the device selection, and there are teams now that are inserting PICCs in some facilities, for example, an RN pair, or an RN and a clinical support pair. The availability of PICC teams has certainly surfaced, especially over the last 4 or 5 years. The PICC team is a very specialized, important part of the patient care team. And oftentimes these nurses only provide PICC insertion. Sometimes they're covering, as you know, 24/7. I would encourage our group, as we look at vascular access and PICC teams, is that we should be considering opportunities for growth of these specialized teams and advancement of the practices, for example, with CVC or arterial line placement. The expertise of these teams is they're quite skilled. They have, due to the repetitive procedure that they're doing over and over, they are accurate and precise. And as we know, the insertion complications are certainly reduced when you have experienced clinicians providing the care. If a device can be inserted early in the admission into the hospital and follow that patient through his hospital course and then on to his home care, it is a cost-effective measure, and it increases the patient satisfaction dramatically. Next slide. Let's look at considerations for some PICC selection. Blood flow dynamics is what Tom has been focusing on today. When we look at we're placing these catheters with ultrasound, which gives us the ability not only to accurately place the needle into the vessel, but it also gives us an additional tool, a tool that we can assess the flow of the blood in the vessel or the absence of flow in the vessel. We can assess the condition of the veins, the size of the veins. There are calipers on many of the machines to give you an exact calculation of the size of the vessel. And in the presentation that Dr. Naifong had, there was a wonderful table that gives you the blood flow reduction and the blood flow remaining in the vessels whenever certain size catheters are introduced into certain size vessels. When we look at the catheter size, that would be comparing the French size to the lumen size. And this is the concept that Dr. Naifong has introduced for us regarding catheter to vessel ratio. And an easy way to remember this, and that will allow you to maintain a approximately 1/3 reduction in blood flow, is to select the French size of the catheter and correspond that to the lumen size in the vein. And an example would be a 4 French catheter into a 4 millimeter vein would allow you to get about a 33% reduction in flow, which means 66% flow remaining in the vessel. When we look at the insertion site, the vein size is generally much smaller at the anacube as compared to on up the periphery, so that may be an option for the clinician as they're inserting the catheter, is to move up the extremity where the vein is larger. Factors unrelated to the venous size and condition include the factors that Dr. Naifong mentioned, such as Virchow's triad. And when we look at the patient assessment, that helps us determine, are there any factors in this patient's condition that would fit into one of the other categories associated with Virchow's triad. What it may do is it may make you think, do I need to place a smaller PICC in this patient? Is this patient a candidate for the triple lumen PICC that the physician has asked for? One thing that is also important that's really come to the surface recently is the location of the distal tip to prevent thrombosis. With the implementation of the various tip location systems that have surfaced over the last few months, this tool is going to give us what we need to place these catheters at the distal tip of the SVC near the cable-atrial junction. And I've taken a quote from Dr. Goldhaber in the editorial comment. Despite our best intentions, the conditions for a perfect storm can arise and predispose the patient to upper extremity DVT. And I think this is an example of when a patient has all of the factors that create thrombosis when it comes to Virchow's triad. Next slide. Positive patient outcomes occur whenever the ordering clinician is educated. Oftentimes this is a physician, and many times they may not be aware of the specific standards that guide the practice in infusion therapy and in vascular access. So he relies on the inserting clinician to provide him with that information. So it is a team effort when it comes to choosing the correct device. Communication is very important between the ordering and the inserting clinicians. The inserting clinician, on the other hand, does have the responsibility to be educated, participating in AVA or the Infusion Nurses Society, networking meetings, any education that your hospital may provide on vascular access. Oftentimes your manufacturers can provide CEU education for you. There are opportunities for you to read literature, and with the internet, there are many articles that can support your education advancement as you surf the internet. So it is very important for us to look at the specific needs of the patient, fluid and medication delivery, but we also need to make sure that the patient does have the appropriate vessel size and not too many risk factors that would predispose them to negative outcomes such as thrombosis with their catheter being placed. And to quote Dr. Goldhaber in conclusion, we must pay more attention to the issues previously considered mundane. They are pertinent to maximize patient safety. So just because upper extremity DVT related to PICCs is not something that we focused on until the last 2 years or so, I agree with Dr. Goldhaber. I think it's something that we really should consider because after all, our goal is to maximize patient safety. That concludes our presentation today. This is the bibliography for you. And now I will turn it over to our organizer.
Thank you very much, Cheryl and Dr. Nifong. We have just a short amount of time, and we have about 5 questions to go through. So I'm going to start right in and say, Dr. Nifong, how important is catheter to vessel ratio when determining when the PICC is too large?
Well, I think that's a great question that really, comes to the major point of all of this work so far. As I showed earlier in the presentation, there are really a number of factors that determine whether or not a thrombotic event is going to occur, considering both the endothelial damage, the underlying hypercoagulability and the stasis, and the exact contribution of each of those is really difficult to discern. But to frame it a different way, what we as clinicians need to focus on are what are the truly controllable factors at our disposal. And so this, catheter size to vein ratio is one that I look at as something that we can impact and we can use in order to try to reduce the frequency of thrombosis.
Okay, and the next question, do you think reverse tapered catheters have an impact on PICC thrombosis?
That's really not a question that I've delved into, in an experimental manner. It's certainly possible that there is an impact, but I know there are some investigators that are specifically looking at that question. I would defer to them in order to really address that.
Okay, and the next question, any information related to thrombosis with right versus left upper extremity placement, male versus female?
There is some published information that shows higher rates with left versus right, but I don't believe that that's been rigorously studied. I know that there are some other publications that institutions will actually utilize the non-dominant arm. And so there are some arguments in both directions. I don't think that it is the overriding concern. In other words, I think when we look at the preventable factors and we look across the overall health of the vessels in the two arms, that's probably more important than specifically whether it's left or right. As far as the gender aspect, that's certainly not a controllable factor from that standpoint, and it has been addressed. It is not. I don't see that it comes up as one of the statistically significant factors in the risk of thrombosis, though.
Okay, great.
Dr. Nifong, I'd like to add something there about left versus right.
Sure.
I think that's more important when you're looking at catheter tip location specifically. The brachiocephalic to the SVC from the left side is a much steeper angle than coming from the right side, so it's very important on those left-sided catheters to get those tips down near the cavoatrial junction.
I agree. That's absolutely something controllable, and there's no controversy over appropriate tip placement.
Terrific. Okay, well, due to time, I'm going to go ahead and end the question and answer session. So, Dr. Nifong, if we could go to the next slide, I just want to review the continuing education credit that is available with this webinar. So, again, to obtain one contact hour, go to www.saxtesting.com/VH, complete the post-test and evaluation form, and your certificate of completion will be issued immediately. I do want to say that this session will be posted to a website by early next week, and it will be there. So there's the website, vessel/health.org, and this information will also be emailed to you as an attendee of this webinar. So on behalf of Sax Communications, Dr. Nifong and Mrs. Kelly, I thank you for your attention today and for attending our webinar. Have a terrific day.
Are we a closed session?